Hello, everyone, and thank you so much for joining us on our webinar today on imaging for the USMLEs, everything from CT scans, chest x-rays, MRIs. We have an action-packed hour and a half for you. My name is Moses, and I am an internal medicine junior, as well as a senior tutor with med school tutors. And I'm thrilled to be joined by my colleague, Roshan. Roshan, could you introduce yourself?
Hey guys, how you doing? I'm also kind of right in the middle of my residency. I'm a PGY2 going into ophthalmology, and I'm also a senior USMLE tutor. So I think both me and Moses have a lot of experience with coming across imaging, and hopefully we can share some tidbits that we've learned across the way.
Absolutely. A quick word about who we are about MST. We are a group of individuals who've been through the medical process, each of us at various stages, who one, have done well on standardized exams, and two, are really passionate about helping folks, really regardless of where they find themselves and what barriers they might be facing, find success. That's predominantly through one-on-one online tutoring. You can see on the screen that it goes from pre-med, the setting, all the way to residency and the boards. Tons of experience, tons of passion. Hope that comes through today. You'll notice that throughout I'll be looking to the side, answering questions that you put in the chat. That's how we'll make this interactive. Please go ahead and put your thoughts in the chat. But I also mention this because for your particular situation, we may not be able to get into the nitty-gritty of advising for you. So at the bottom of your screen, you'll notice various ways in which you might contact us, including social media accounts, a phone number, as well as an email address. And so I really am looking forward to hearing from you, and the rest of the team is as well, I'm sure. So quickly, just to set an agenda for tonight, like I said, it's action-packed because we feel that we could give you all sorts of didactics, but the best is to learn by seeing pathology through imaging. So we'll start with an overview of some tips that we have for you, specifically in integrating radiology findings in the setting of these examinations. And then we're going to systematically go through these various modalities of imaging, giving you both an approach to these modalities, as well as examples of high-yield pathology that could show up on your examination so you can get those extra points. And so with that, I'll turn it over to Roshan to give us some general tips on approaching radiology.
Hey guys, yeah, so I think the most important thing when it comes to these radiology questions is understanding that there's no expectation that you are a radiologist, and that's the reason I mention that is because the key here is that the vignettes will often give you most of the clues that are necessary. And a lot of times what can happen is that either you could see an image and say, oh, okay, just by immediately seeing the image, you recognize pathology. And that's kind of what they're looking for, or they're just willing to tie it all together. They're giving you most of the clues from the vignette, and then they're saying, okay, let this image, be the icing on the cake. But the key here is that you're not expected to look at some random esoteric image and know exactly what the diagnosis is. And if you are, then it's very clear what the diagnosis is going to be. In medicine, we love our saying, common things are common. And that's the same thing with imaging when it comes to, the USMLE. They'll be very, clear about not giving you anything particularly difficult, very common images, very common pathology, because that's what you're going to be coming across the most in your clinical experience. Now, the big point, and this is something I want to, I know I just mentioned this, is that don't be worried if you don't immediately know what's going on in the image. What we're going to do is go over a couple things that we think are particularly high yield, and within that, discuss a little bit of anatomy as well. And what we hope to do with that is then basically help you understand that, okay, even if you don't know exactly the pathology that's going on in the image, you can probably, use enough clues from the context and recognize what you do know from the image to answer your question. And that's kind of the big point of what we're trying to go over here. So without further ado, we're going to start with going over some chest x-rays.
Beautiful. And first, like I mentioned, we just want to give you an approach. We know that time is precious on these exams, and you're not over here writing a formal radiology report. But in general, you do want to have a systematic approach, particularly if you don't know what's going on. Maybe you're spending a little bit more time on this question. And this is definitely applicable in the real world when you are interpreting these images for patient care. You want to stay organized. So here's a common organizing framework that is taught in many med schools that involves the ABCDEs of reading a chest X-ray. And that involves first looking at the airway and the mediastinum. Why? Because if the trachea is abnormal in some way, that can be a clue to some pretty serious pathology. You don't want to miss that if you jump straight to the heart or straight to the lung fields. B stands for breathing and bones. If you get a vignette that has some trauma, for instance, as part of the presenting symptoms, make sure that you're looking at those bones. Is there a fracture that could be the cause of pain, that could be the cause of a pneumothorax, for instance? Moving on to C, we have circulation, and that involves an analysis of the heart, both subjectively its size, and we'll show you examples later on where that's relevant, but also are the cardiac borders well-defined, which can give you clues to what might be going on in adjacent tissues, such as the lung parenchyma. Next, we're looking at the diaphragms. Are the costophrenic angles nice and crisp, which would make the presence of a pleural effusion less likely? And remember that the chest X-ray can sometimes give you information about extrathoracic structures. So make sure there's no free air under the abdomen that could really be a clue for a catastrophe going on in a different part of the body. And lastly, it's extras. All the other stuff gets lumped into this category, which includes hardware, things that we put into patients, anything from intubation, so you have an ET tube, to pacemakers and defibrillators, anything that would be picked up on a chest X-ray as being hyperdense. So this is all well and good, but you've got to apply it to actual cases. So next, we'll show you a normal chest X-ray. Roshan, could you mind walking us through a normal chest X-ray?
Yeah, so kind of what we're showing here is your basic outline for the heart. The keys here are exactly what Moses mentioned. So you want to get your big anatomic landmarks in place. So once you kind of get an idea of seeing enough of these, you'll start to get a clue. But if you look from an ABCD standpoint, right, the A, you're going to look and you'll see a very clear demarcated airway. And it may not always look very, very clear, but you will notice that it's going to be overlying the vertebra. And it's a very, if there is pathology there, it'll be very apparent that there's something going on. Next, when we talk about the bones, right, a rib fracture would be pretty evident. If you see kind of just anytime you see a fracture, you're going to see a break in the image. So it doesn't look like these smooth lines here. All the ribs look very smooth. You don't see any breaking of the, of that contour. And the other big thing that I want to point out is that when you're looking at these chest X-rays, you want to make sure that you don't like exactly what Moses said. You don't immediately just look for the pathology. You have to kind of have a systematic approach. But when time is precious, you'll have to figure out what's important, what to look at. And then think about when you talk about breathing. Are the lung fields, do they look normal? Do the lungs look overexpanded? Because that could be a sign of pathology. From a circulation standpoint, you're looking at the heart shape and size. There's a common rule about like how much space that the heart should take up on your chest X-ray. And if it's taking up more than, that 2/3 measure, then okay, all right, I'm concerned for that someone's heart might be enlarged. Another thing that I think they love to test on are just the costophrenic angles. If you don't have that, that McDonald sign for your costophrenic angles, then what that could indicate is that, okay, maybe there's some edema there. And maybe you have, some sort of pathology. And then you're also looking under the diaphragm. So not only are you looking above and like looking at the contour, but if you have, for instance, air under the diaphragm, then that's also a concern. But all of this is not evident in this picture, for instance, because this picture, we have a very clear, well demarcated, now that we're at the heart, you can clearly see that the heart's not taking up too much of a significant portion of the image. The diaphragm contours look very smooth. You don't see any blunting of those angles, and you don't really see any air. You do see the gastric bubble, which is something we want you to keep note of, but you're not seeing frank air, and that would be right under the diaphragm itself. And the last thing we want to just briefly go over is just things that are extra. But that's something that when you're interpreting an X-ray is something you're focusing on more. However, it's really something you're going to be less likely to see when it comes to step 1 and step 2.
Beautiful. Here we just have a lateral view, not much more to add. I think this is less frequently encountered on examinations, this lateral view, but just so that you've seen it once. There are a couple different types of opacities on chest x-rays. Honestly, for step one, this is not really tested. We're going to jump right into some pathology. So without further ado, take a look at this chest x-ray. And in the chat, please put in, what do you see here? What sort of pathology are you finding? I'll give you 10 or 15 or so seconds. And I'm looking over here at the chat to see what folks are saying. Remember, it's anonymous in the chat. No one else but us as the presenters can see it. So please don't be shy. Don't be shy. And just to illustrate how the history can be very useful, what if I told you that this person has an ejection fraction of 10%? Right? And they're coming in feeling really short of breath, and maybe they've been missing their medications. And immediately what you'll notice, I'm noticing in the chat, is that folks are getting to the right answer really quickly with that extra little bit of clinical history. So this is an example of pretty dramatic pulmonary edema, right? Where you see the edema is filling up the alveoli in the lungs. It's causing an opacification. It's bilateral, and it's really obscuring a lot of what else is going on in the image. I'm having a really tough time interpreting the heart size, for instance, but I wouldn't be surprised if it was enlarged in the setting of heart failure. So again, really driving home the point, the clinical history plus the image really helps you get to the right answer. Roshan, what do you think about this next image?
Yeah, so, here I have a much better view, but now my concern is that, like, I feel like it's almost like I'm seeing too much, right? Like, so the question then explains, like, why do I feel like I'm seeing more? Is it, and what am I seeing more of? Is it that the ribs are more apparent? Good, and I already see people participating in the chat, which is exactly right. These lungs look just hyper expanded. It looks like I'm just not able to get air out of there, and so. The big thing here is that if you look at my, I like to have like these associations where, similar to when you do questions and you have buzzwords, if I see a certain sign and that diaphragm looks very flattened to me. So as soon as I see a flattened diaphragm, I feel like I'm seeing more ribs than usual. I'm immediately thinking of like a COPD emphysema-like picture. And that's kind of like, that's kind of the thought process. I think a lot of people are getting the answer right. And they all are you're probably using these like middle mental clues. And it's important to just kind of key in on those. And then sometimes this is an example of something where maybe they would give you the image and they're not going to give you so much history and say, patient complains of shortness of breath, a chest x-ray is ordered. Which of the following risk factors might this patient have? And I know that, for instance, smoking is something that's very high on my differential, would be a very good answer choice for this answer.
Phenomenal. Next, we have another image that is really related to high yield pathology. And this is also a great example of why the ABCDEs are so important. So if I start with the airway, it's a little subtle, but there might be a little bit of a bending. There might be a little bit of a asymmetry with that. And then if I look at the lung fields on the right side of the screen, which is the left lung, I'm seeing more it's not even an opacity, but there's just a little bit more whiteness on that side. And on the right, especially peripherally, very, very black. And I'm going to use the pointing here to point out that there is an outline here that I'm tracing. So what if I told you that this patient came in with some shortness of breath and they look sick and maybe a little bit of low blood pressure too? Yeah, so folks in the chat are really jumping all over this. This is a tension pneumothorax. And so here, the patient would need to be rapidly decompressed, right? Like mid-clavicular line, second intercostal space, because this can have both respiratory and hemodynamic implications. So tension pneumothorax here. All right. Here we have both an image and a vignette. Roshan, let's walk through this.
Yeah, so we're talking about a 34-year-old African-American woman with a history of asthma who presents to the emergency department. They're complaining of a dry cough, worsening shortness of breath for the past 6 months. There's a decrease in her visual acuity, so I'm now particularly interested in this patient. And her family history is notable for a maternal aunt who died suddenly from cardiac arrest at age 41. Physical exam reveals these vital signs. Everything looks relatively okay. But there is decreased breath sounds at the basis bilaterally. So before I even continue, the one thing I want to make clear is that this vignette is just laden with information. There's a lot that you can get from just solely this vignette, and something that I honestly feel like you could confidently answer this question. But now what we're going to do is we're going to quit, the labs. I would just have you, I'm not going to read them out, but I'll have you guys take a look, try to see what pops out to you as abnormal, and take a look at the chest x-ray. And I want you guys to take about 10-15 seconds, try to put it all together. I already see some answers, and a lot of them are correct. But I want you to mentally think about what are the 3 most important parts of this question that probably are leading you to the answer. Okay, both in terms of the image and the history. All right, so the big thing I want to point out is that there was clear, hilar adenopathy. Okay, and whenever you see bilateral hilar adenopathy, there are buzzwords that need to be going on in your head, and the most common one I would say is sarcoid. But if you see that, if you compare it to if you mentally compare, and something that, we're going to try not to reference images too much, but we just went over a normal x-ray, there wasn't that prominence right around the mediastinal area, right? But now you do, and Moses is doing a very good job of just outlining that for us. That's very clear hilar adenopathy. Okay, and that's very pathognomonic for sarcoid. It can happen with other conditions, but sarcoid is the immediate kind of pathology you want to be thinking of. The other really key points, they're talking about a patient who has a history, who's African American. Okay, African Americans are particularly prone to, for instance, sarcoidosis. So that's something that you want to keep in mind. There's also a concern for decrease in visual acuity. What they're getting at there is that she probably has a uveitis history. And uveitis is very commonly associated with sarcoidosis. So now if you see, just from reading this question, you could get a very clear idea what is probably going on. And then finally, you mentioned that, the maternal aunt had died of cardiac arrest at age 41. Why is that pertinent? Maybe because sarcoid can be an infiltrative cardiomyopathy, which could then cause, some sort of electrical issues and then cause cardiac arrest. So now putting it all together, this is kind of what we wanted to reference, is that very clearly you could have answered this question even without the image, and the image is just to give you that last bit of information. And so that's why the answer here is sarcoid. Some of the other answer choices we are going to go over in future slides. So I'm not going to go over all of them. The couple things to note are, for instance, asthma, you actually will usually have a normal chest x-ray. You're relying more on the history with asthma and relying on your your pulmonary function test. So just, the other thing to keep in note is that this image, for instance, and that's what we're kind of alluding to there, can be used for a lot of different questions. They're asking about if you wanted to know about the disease process, from a autoimmune standpoint. Why does this happen? What are the complications that this patient can develop? Today we're going to be focusing on imaging, but that's kind of something that we added because we want you to understand that when you're reviewing questions, especially when it comes to imaging, there's only so many different ways they can ask you something. And so if you start to get in the habit of saying, okay, how would I, have answered this if they presented the question this way? Or if you see a wrong answer choice, what would this wrong answer choice be the right answer to? You'll definitely start feeling more and more comfortable with these pathologies in these images.
I love that. And leave it to an ophthalmologist to point out the uveitis. So good.
That's the most interesting part.
I won't get into a beef with you on that. As the internist, I might have to disagree. But folks in the chat are also pointing out the calcium, the alpha hydroxylase. Love it. This could go in so many directions. In the interest of time, we'll keep it moving. But thank you so much for your engagement. Here we have another image for you, very pathognomonic. If I told you that this was a child, that they had a barking seal cough, what would you be thinking of? And really getting at that A, the airway, really important. In the chat, all over it. This is laryngotracheal bronchitis, the classic steeple sign that I'm outlining right here. Classic for croup. Beautiful. Maybe I'll just quickly go over a CT scan and have Roshan go over the next abnormal. I will say this, again, you are not supposed to be a radiologist. Typically, if you're looking at a CT scan, it's going to be pathology that is super straightforward, super common, glaring abnormality, and you should already be 80% of the way to your diagnosis. The CT scan clinches it. Remember that the CT scan is of a patient lying on their back, and imagine their feet coming out of the image towards you and their head, they're facing upwards, their head coming out the back of your screen. On this scan, you can see the aorta in A, central, above the L2 spine, the IVC to the left of that, anatomically on the right. You see the major organs of the abdomen, the liver, the gallbladder. You see the 2 kidneys. You see the large and small intestine. Spoiler alert, I still have trouble telling the small and large intestines apart on the CT scan. Don't worry about it. That's not something that you will really have to deal with. And of course, at various levels, you can also see the pancreas, which is not explicitly shown on this slide. Anything else to add? High yield things for examinations that folks should be able to identify on CT abdomen pelvis, Roshan?
I think the big thing that you kind of allude to, and I just want to repeat, is that, you know, as we mentioned, you're not expected to fully really recognize, you know, these CTs in every slice. But one really high yield thing about CTs are just getting your orientation correct. So if you look on the image, what Moses mentioned was that, you know, the liver appears to be on the left side, which you always associate the liver on the right side, right? So the key here is that there's 2 things I want to point out. One is that if you know, for instance, you know, that you want to have at least some anatomic understanding of some key landmarks. And for instance, the liver is always on the right side. So you can use that to guide you and figure out, okay, where am I? But the reason that the liver appears on the left is because when you're looking at these CTs, it's almost like you're looking from the patient's perspective from the feet up. So if I was looking at the patient and the feet, you know, looking from from bottom to top, that's how the orientation is, that the liver would appear to be on the left, even though on actuality, they're showing me the right side of the photo. So just make sure, you know, usually it doesn't come up too often, but that you don't get too confused by that and then you get, you know, all mixed up. So remember your anatomic landmarks, and then more importantly, just remember that CTs will be a little bit disorienting once you first get the hang of reading them.
Beautiful. I will not spend a ton of time on this. The aorta bifurcates. It initially is sort of above a particular spinal process, and then it sort of moves laterally and then bifurcates into the common iliac arteries. Just to answer someone's question in the chat, how do we know what part of the vertebral body we're looking at? Typically on the CT scan, you're not going to be expected to know exactly which vertebra you're looking at. So I would not worry about that. I would really emphasize what Roshan said, which is just orient yourself and know where things are relative to each other, and correlate that to the information that you're getting in the vignette. The same goes for the IVC, actually. Here in purple, you see how it looks like at various parts of different slices of the body. Again, you're thinking of pathology of the IVC, right? Like it's draining everything from the lower part of the body. Lower yield to be able to identify this specifically on various CT scans. Roshan, anything about solid organs that you think is particularly high yield on CT scans?
Yeah, so I think kind of to go along with what you're saying is that having an idea of what they look like, but knowing slide by slide, you know, in different cuts, the liver will appear a little bit different. But if you can kind of, you know, I would say the heart, you should want to be able to clearly recognize, and you know that, okay, if you know, it's surrounded by this kind of area of like very much like of darkness, that's indicating that we're in the lungs. If you can recognize that, you know, the liver and the spleen will share a window, just get an idea of where things, you know, what other organs do these do organs share with, and then you can get an idea of where you're at. So even if you can't always recognize the pancreas, like I remember sometimes I struggle with that, knowing that if it's in the area of the liver, it's kind of more retroperitoneal, okay, it's probably the pancreas. But that's kind of basically you know, you should be able to obviously recognize what the kidney looks like, what the liver looks like, but that's something I'm very confident that just after a few questions, you guys will be able to do. Similarly, when it comes to the rectum and the colon, you know, much like Moses, I'm probably even worse at looking at these at kind of like bowel imaging. But I'll be honest, I'm pretty confident that most of these bowel imaging questions I'll be able to get right, because there's only so many different ways that they can ask them, and there's only so much high-yield pathology that relates to that. And okay, and one thing I want to point out, someone in the comments just mentioned that like how they remember where the pancreas is, where you know, they remember that it you know, tickles the spleen. That's something that I really like, because everyone, I found that this was so helpful for me. Everyone has their way of remembering things, but it's as long as you devise your own way of remembering it, then you're probably not going to forget it. Sure, you can use other people's mnemonics, you can use other people's insight, but if you figure out your own mental way of organizing things, you're probably going to be very set when it comes to then remembering, these key associations, not just when it comes to imaging, but also just questions in general. And then we're just going to go, right past that, the esophagus and the small intestine. And, we have some very interesting pathology here. This is an example of something where, they might just give you this image and it's so high yield that it is important that you recognize it. So what I would do is I would kind of briefly scan through the CT. Maybe I would just go top to bottom. What looks abnormal for me? I know that I'm working with the heart. I know that we just went over the vessels and I'm in the lung field. So I've oriented myself. Now, what just looks abnormal to me? And I obviously, I think I'm getting a lot of answers. I look at that aorta and I see that, oh my God, there's this area of hyperlucency that looks like, it's potentially, is it potentially clot? Is it something? All I know is that it's abnormal. But what you kind of are getting is kind of that double lumen sign, which is very consistent with an aortic dissection. And so this is an example of something that it's high yield enough, and that you should be able to recognize. But once you see a couple questions, then once you recognize pathology, how would they ask me this? Maybe they're describing someone with tearing sort of chest pain. Maybe they're describing someone with different blood pressures in different sides of their body. So once you have a basic idea of the image, then you want to think about how would they test it. But there is certain images, for instance, like this one, that even if you didn't know exactly what was going on, you should be able to recognize that something is abnormal, and hopefully work your way into finding out that, okay, that's probably the aorta, and there's probably something that is going on with the aorta, and then be able to identify pathology accordingly.
Beautiful. And really in that same vein, we have another image, potentially slightly less high yield in terms of just being able to see the image and immediately knowing the diagnosis, but still something that you want to catch. Here, someone was a little prescient in the chat, because I'm just going to point or use the pointer to highlight the area of pathology here. Someone in the chat said it's giant. And that's right. So if this is a patient who came in and you were doing an abdominal exam, which by the way has happened to me, you're doing the abdominal exam, hopefully you're assessing for pain in the various quadrants, and then you just feel this pulsatile mass. Folks in the chat are already putting the correct answer. I'll give them 5 more seconds. Beautiful, an aortic aneurysm, in this case with a mural thrombus. That last piece slightly less high yield. But again, think about the scenario in which this might be tested. It might be someone who has a history of smoking, right, which is a risk factor. You might be thinking about hypertension. Some of the associated ways in which this might be tested on an exam. Folks in the chat, thank you so much for participating. Excellent work identifying this aortic aneurysm.
So this next one, I'm going to go over quickly, not as high yield, but what you're basically seeing is that there is some sort of abnormality with these areas of hyperdensity. If you don't know this, I really wouldn't worry about too much. This is an IVC filter. What's more important is that maybe they would even tell you, they would give you enough information. And the way that I can see this question, imagine this question, is that they give you a question and they say the patient, they'll give you a contraindication for why the patient cannot be on anticoagulation. They have a history of frequent falls, et cetera. And they say, they decide to proceed forward with this intervention. And then, what is something important to monitor? And then, these IVC filters, for instance, are not meant to be permanent. So maybe that, this needs to be examined and maybe removed in the long term. If there, for instance, was a reason that they were only temporarily unable to be anticoagulated, or they would give you a history and say, what was the reason that this patient needed this specific device? And you would say, okay, because they can't be anticoagulated. But I don't want to delve too much into this, but the big thing here is that, there's so many different ways they can ask about imaging, but one way is that this can just help you be 100% sure of your answer. But even if you don't know what's going on and you're 90% sure, the chances are you probably are right.
Beautiful. And in that same vein of calcifications, things that are slightly lower yield, I'll breeze through an aortic calcification. Big clue here. If the patient did not get contrast, anything that lights up and looks like bone is probably calcification somewhere. So that's a big clue. Here I'm highlighting the calcification, and you can see the really nice alternative view here in B and C where you can see the extensive calcification. I do want to focus on this one because one, it's a condition that is super common in the population and really high yield for testing purposes. Here you have a patient. This is a cut through the abdomen. Again, it looks like some sort of bowel is being visualized here. Folks, yep, in the chat, perfect. And already giving the answer, this is diverticulosis. And what's interesting is remember that the difference between diverticulosis and diverticulitis is inflammation. The itis refers to inflammation. So you would expect both to see clinical as well as radiographic evidence of inflammation to help distinguish between the two. And to that very point, the major thing that you would be looking for on imaging is some fat stranding. Again, will they be asking you necessarily to identify the fat stranding? Probably not, but if you see it, it's a good hint, as well as thickening of the wall. Again, pathophysiologically related to the fact that there is inflammation going on in that site. All righty, take it away.
So now we have another radiograph. The key here is, recognizing that this is a plain film and that we're probably dealing with like a pediatric patient because we're getting so much exposure in this small field. So now what I'm looking at is that, I can very clearly see that there's some pathology going with the bowel. I don't know exactly what, but, maybe I can work my way through it. So then, okay, I'm looking a little bit further. It looks like, two things are very apparent to me. One is that, the bowel is especially prominent. And so if that's the case, and they give me the right history, what is something that I'm, what am I thinking of when I think about a baby that has some sort of bowel pathology? What's like the number one thing on my mind? Okay. And that's how I kind of approach these. And, a lot of people already have the answer. And the answer is necrotizing enterocolitis, right? So now this is an example of I obviously recognize the picture, but that's kind of would be my thought process if I didn't recognize it. Making these associations is the most important thing. And so here, just to kind of outline the features, what you're seeing with this necrotizing enterocolitis, I shouldn't be able to see this very, very prominent bowel. But what you look at is when what Moses is kind of circling for us is that it almost has this tram track appearance, right, where you can see two distinct lines. What that means is that there's air inside the, surrounding the colon, which is pathognomonic for necrotizing enterocolitis. Another way that they could have showed you this is with a baby that has air under the diaphragm, okay? Then you're concerned for perforation of that necrotizing enterocolitis. So that's, once again, an example of ways that, I'm just thinking about different ways that they could ask, but common things are common. A baby with bowel pathology, that's the main thing you want to be thinking about, necrotizing enterocolitis. So you want to be able to recognize it and then think about different ways that they would ask it. Awesome. Good. And and one person mentioned that this is very common with premature babies, and that's definitely the case. Not something you'll see usually with a normal baby.
Love those pearls. Here we have another image that's really, really quite classic. And I'll start, as you all put in the chat, what you think might be going on here. I'll just point out that the human body loves symmetry and the human body loves homogeneity. So typically, with exceptions related to embryology, the lungs should look fairly similar on both sides on a radiograph. Various organs should be homogeneous. In this case, the liver should have a homogeneous appearance on imaging. And what if I told you that this is an older individual, that they have risk factors like perhaps smoking, excessive drinking, maybe a family history of malignancy? Then you're thinking, I'm in the cancer category. And because this is multifocal, and I'll point that out for you, these hypodensities through various anatomic portions of the liver really raise suspicion for some sort of liver metastasis. And you all in the chat are way ahead of me because the next question really is, where's the primary tumor most likely located? The key here is thinking about the drainage, the venous drainage of the abdomen, and the fact that the liver is really the point where all of it comes together. So specifically, we're thinking that the colon is the most likely cause because that venous drainage from the colon is drained through the liver on its way back to the heart. So again, colon cancer, multifocal, you're thinking of a metastatic type disease. So here, just illustrating the principle that organs should generally be homogeneous in appearance. And when they're not, folks in the chat were pointing out, sometimes you can see imaging consistent with cysts, other infectious findings. You can have primary cancers of the liver, but you use the history, you use the image to help you get to the right answer.
Yeah, I really like that point about the homogeneity. And that's something that, like, I feel like is not something that I ever actively thought about, but something that now, you know, as I'm thinking about it, you know, I'm like, that's something that kind of just is in my thought process whenever I'm seeing something, you know, and that's something that mentally, it's a great way to think about things that we're so, you know, you're used to a uniformness when you're looking at certain tissues. And even when you think about the aortic dissection question, that's kind of like what I was doing, but I wasn't able to articulate that, is that as soon as I see a deviation in that like homogeneous appearance, I know that there's probably something going on. You know, as soon as something doesn't have the symmetry about it, there's an irregular area of like hyperfocus or, you know, hyperintensity, hypointensity, there's probably something going on. And I think that's a great tip and something that I think will probably guide you guys a lot when it comes to imaging going forwards. So the next slide that we want to go through is one where suppose, you know, this I think is a very good example of like kind of homogeneity. We see, you know, that there's some area, you know, so the important thing here is, you know, what organ is being affected. And that's something I want you guys to think about. And the other thing is that, you know, what type of history. So I want you guys to really think, if you were able to identify the organ, identify the pathology, take 15 seconds. And if you'd like to participate in the chat, what do you think could cause this pathology? Okay, so we're getting some good answers. So, you know, the big thing, and you know, the number one answer we're getting is trauma. Now, trauma is a good answer, but I don't think it's the best answer. And the reason for that is that this is a very specific area of, you know, demarcation in terms of like, you know, this is definitely an infarct, right? We have normal tissue, and then next to it is tissue that looks like it's been infarcted. Now, what about like that shape of it? That kind of looks like to me like a wedge-shaped area. And if you think about the way that arteries and veins spread, the arteries kind of spread in a web. And so one of the webs and like kind of one of the areas would be, if an artery is infarcted, it's going to cause a wedge-shaped infarct. What's going to cause you to get an artery to be occluded or infarcted? And the number one answer would be a you know, a thrombus. So the history that you're looking for is atrial fibrillation, where, you know, a patient has atrial fibrillation, they throw a clot. Not only would you have it in the spleen, but you're probably going to have it in other spots. You're going to see, they may give you clues about rod spots, you know, Osler nodes, but just keeping that in mind, you know, just how are you correlating the image to the story? A quick note, a lot of people are mentioning sickle cell. Now, that's great that you're recognizing that the spleen is going to be affected in sickle cell. The thing about sickle cell is that those are kind of more of an auto infarction of your spleen. So the spleen is just going to look shriveled. It's going to look calcified. And, you know, I think from what I understand, it's like I remember a fact that like by the age of 12, you know, a very large percentage of sickle patients have already auto-infarcted their spleen. So you wouldn't even be able to see that much healthy spleen tissue. You'd be seeing a very, very smaller, you know, very shriveled up spleen. But that's kind of, you know, I spent a little bit more time on this picture. You know, it is kind of high yield, but the other thing is just working through the logic. Exactly, you know, from point A to point B, why are you getting this specific sort of defect?
Beautiful. Just to respond quickly to someone's comment about the retroperitoneum, you know, in this case, it's not the focus of the pathology. Retroperitoneal bleeds tend to be a little bit bigger, a little bit more obvious. It also depends on which phase of the CT and like the settings that make it look lighter or darker. In this case, I think the real pickup is the lack of homogeneity in the spleen, and then the beautiful pearls that Roshan just gave us. Here we have another example. And to make this more true to the experience of taking a test, I'm going to give you the history up front. This is an individual, let's say, whose triglycerides were 1,300, came in with abdominal pain. This all happened about 3 weeks ago. And then, you know, they were treated with fluids and pain medications. They ended up going home. And several weeks after the bout of what we think of, it might be an acute pancreatitis, they maybe still feel a little bit of fullness. For whatever reason, they get a surveillance CT scan. What complication of acute pancreatitis would we be seeing on this scan? I'll give you 10 to 15 seconds. Folks are saying, you know, so first of all, let me just say that I'm pointing out that there's this circular hypodense region on the scan. And the two answers that I'm seeing in the chat are pancreatic pseudocyst, and other people are saying abscess. Let me point out that, you know, superinfection of the pancreas, massive inflammation, definitely possible. But here, several weeks out with a clinical history that's a little bit more benign in the sense that it's more abdominal fullness, really favors a pancreatic pseudocyst. Remember that abscesses are nasty. They're destructive. They have sometimes areas of fluid intermixing with different densities. If it's a gas-forming organism, you might even see gas. This looks remarkably well circumscribed. This looks really homogeneous despite being different than the adjacent normal tissue. All of this favors a pancreatic pseudocyst as opposed to something like frank ongoing necrosis with superinfection of the pancreas. Anything to add here?
No, I think I think the big thing that you mentioned is the distinction between the abscess and the pseudocyst, and I think that was like very well explained. Something I would just keep note of whenever you're kind of confused about, you know, if something is well demarcated, what type of pathology. If something looks a little bit more messy, what are you thinking of? And I think that'll really help them out.
Beautiful.
So really quickly, kind of what's going. You know, this photo, it's not, I want you to, everybody in the chat to take a second, try to think about what's going on. If you'd like to answer, definitely give us an answer. It's not as obvious as you would think. The big thing here is just, I like to stress is knowing anatomically where you're at. And okay, so what are you seeing? You know, I think I'm making out a little bit of the kidneys. I think, you know, I see that it's more retroperitoneal. I know that based on kind of my general understanding is that I'm in the GI kind of area. Okay, fine. I see this very much area of like hyperdensity above the kidneys. It's probably some degree of pathology with the kidneys. And what we have here is hydronephrosis. So this one's not as easy as it looks. I think for a lot of people, they're thinking that this is a slam dunk, but it's hard to orient yourself at times. You know, you're not getting very key anatomic landmarks. And the key, I think, for this question and this image is just realizing that immediately it may not be very clear what you're working with, but if you kind of look around, look for familiar sites, you'll be able to kind of figure out where you're at.
Beautiful. And I'll just add, this patient probably has an AKI, right? Then what are the other things you might see in the vignette? You might see the elevated creatinine and BN to creatinine ratio more consistent with a post-renal process. You might have the patient give you a history of unable to urinate for some time, or maybe a history of a malignancy or something else that is leading to this obstruction of the urinary tract. Yeah,
and you know, to actually go along with what Moses is saying, like, you know, then the next step is, you know, they give you this and they tell you that, like, okay, so you know what the treatment is that, like, suppose it's a stone, you evacuate the stone. But what if the patient's really sick? They're just like not hemodynamically stable. What can you do as a result of that? And suppose you had an idea of what's going on, and you think, okay, it's a bilateral obstruction. I can just remove the stones. But then that's what I mentioned, that they're very, very sick. They may not be safe for surgery. So maybe you have to get interventional radiology involved. So just kind of keeping this and doing like a tube nephrostomy. So just keeping in mind, you know, sometimes the images will be really simple. You'll think you'll know exactly what's going on, but make sure you're reading exactly what the question is asking.
Beautiful. Here, so you've seen it once, the coronal view of the abdomen. I actually think this is a really nice way to get that anatomic framework. Remember, left is right when you're looking at it on a screen. So on the left side of the screen, but the right side of the body, you have the liver. This is the portal vein. It's draining all of the intestines. This is, if you have a cancer here, it has a beeline straight for the liver. We talked about the pancreas. This is where that pseudocyst was, right? The bladder. and it's not shown in this particular cut, but the kidneys are behind there. Maybe the bladder is really distended if there is downstream obstruction. Just pulling all of this together. No pathology here per se, but just a really nice view. And then again, just some more cuts of the CT. Here you have the chest really focusing on the various chambers of the heart as well as the vasculature. Most of this not directly tested on the exam, but it's good to have an anatomic sense of where things are. And so I'll then walk into this, this abnormal image. And again, the history is king and it comes first. So let's say that this is someone who had a bit of a cold. Maybe no specific virus was identified, but they had a clinical history consistent with a cold. And now they're coming in to see you and you notice that they're a little bit more hypotensive. You do a good cardiovascular exam and you see some elevated JVP, the jugular venous pressure. And maybe you auscultate their heart and it's just a little bit tougher to hear the clear S1 and S2 that you're used to for this patient. And then they get this image and folks in the chat are already chiming in with the right answer because this is a pericardial effusion, which could progress to pericardial tamponade. There's also some evidence of a pleural effusion. You see that layering in the bottom of the left lung, right side of your screen. So things to point out. Clinically, the hemodynamic impact of a pericardial effusion relates more to the speed of accumulation of fluid more than the absolute volume, because that pericardium is very stretchy. But however, if a previously completely normal pericardial space suddenly gets even a minor amount of effusion, it might have significant hemodynamic implications. Whereas someone who is slowly accumulating, maybe a malignant effusion, then and they might be able to compensate to a greater extent.
A quick note about that there are different windows. So you may notice that, like, sometimes you're seeing, different, a different presentation than what you're used to. Very often you'll be getting the bone window. This is just a quick example of what the lung window looks like. You're able to actually very much see the bronchioles and get an idea of what the air spaces are like. And then if there's any pathology, sometimes the lung window will be a little bit of a different view that you're not used to, but will very easily point out certain pathology. So without further ado, this is a lung window. What does it look like it's going on here? You guys just saw a normal kind of lung slice, and it looks like a lot of people are spot on already with what the pathology is. The big thing here is that, if you see enough normal images, and the key is that if you're seeing these normal images and, during your interactions in your clinicals, you're probably going to hopefully see a lot of normal chest x-rays, and you should try to interpret them yourself so that when you see pathology, you recognize, okay, this looks a lot different. So what Moses was outlining for us, and what I'm going to ask him if he doesn't mind doing again, is that those bronchioles are extremely dilated. You should not be able to really trace out where the bronchioles are. And what that tells you is that because they're dilated, you're probably dealing with bronchiectasis. Now, when it comes to bronchiectasis, yeah, it's important to recognize it, but the other thing is, what is the most common pathology that's going to give you this? And so this is an example of one where, suppose I didn't remember the exact answer, right? But they gave me a couple of answer choices. I really think that this is something you could work through. So the answer here is cystic fibrosis. But what I want to point out is that why is it cystic fibrosis, and why does bronchiectasis make sense? Well, we know that cystic fibrosis is an issue where you get like this constant mucus plugging, right? If the mucus is getting plugged and you're not able to kind of evacuate that, and they need all these special medications to help them do that, and even like manual percussion, then everything has to, if it can't go out, then everything is going to get backed up. If everything is backed up, and by that I mean the bronchioles, they're going to become dilated, and you're going to get this stasis, and that's what's causing the bronchiectasis.
Beautiful. Here's another really classic example, dramatic. The history here potentially is someone who has been exposed to the incarceration system, the penal system, or someone who is immigrating from an endemic part of the world. and folks are all over this. This is miliary TB. Again, miliary referring to that appearance that looks like scattered small nodules all over the place, suggesting a hematogenous spread of the tuberculous bacillus. Again, they could take this and test it in any number of ways. It might be a diagnosis question. They might ask you about the most common treatments for TB, right? They might ask you about the most likely exposures. All of this is fair game. This is just priming you to think of this particular form of TB, miliary TB.
All right, so the next image, and I think, we're going to do these in bunches, but this one is pretty clear that there's some sort of pathology going on, but the big thing that you need to notice is that you have this very significant cavitation, like almost like a hole in the lung. What's something that's, immediately popping to mind? That's what I want you guys to start thinking about, is that if it's very, very clear and, what the pathology is, then it's probably going to be a little bit of a higher order question, right? So what are you thinking of when you see this? Okay, I see that I have a very clearly well demarcated area. I know that I have a cavitary lesion. What's causing a cavitary lesion? Probably something like TB, right? That's like the main kind of pathology that's causing this very large area of cavitation. Some people are mentioning an abscess, but remember what Moses mentioned, that in abscess, it's not going to be as clean. If we had an abscess, we'd see other signs of kind of surrounding, potential tissue necrosis, tissue death. And so that's how you're getting an idea of, that this is probably, we're working with TB. Now, we're going to go to the next image. And now this is what a higher level question is. Maybe they give you both of these images and they say, the patient has a history of TB. Now they have kind of worsening systemic symptoms. And they have like this worsening fever, and then you do a biopsy and you see something. What are you expecting to get from the results of this biopsy? And a lot of the people, a lot of our audience is all over it, that we now probably have a fungal overlying infection into that that cavitary lesion, and that would be an aspergilloma. So now we have this area of like very dense hyperdensity. That's not just going to be blood or empty space. That's something that's filling it, most likely fungus. And, then maybe they would need you to recognize that when you do a biopsy, you're expecting to find some sort of fungal elements.
Beautiful. And similar to the two prior that were connected, I'll do the next two. Here we have a finding, and I really love the way Roshan talked about the wedges, the wedge-shaped infarct. Here, it's not so much a wedge, but let's say that this patient had trauma. We're going to compare and contrast this one to the next pathology, which might be more likely to have some sort of wedge-like infarct. Here, as folks are pointing out in the chat, we have trauma, really peripheral. This is likely a pulmonary contusion. But now what about this image? Here, notice that the window looks different. I'm just going to go back and forth. Notice here we're on a different window where you can see really nicely the lung parenchyma. Here, we're not so much focusing on the lung parenchyma. We're focusing much more on this pulmonary artery. And if I told you that this person just got off of a 22-hour flight, their right foot is more swollen than their left, they're dyspneic and they're tachycardic, everyone's all over this. This is where you might be suspecting a pulmonary embolism, in this case, a saddle pulmonary embolus. A few additional things. Put in the chat, what's a common EKG finding in PE? I'll give you all 5 or 10 seconds to think about what might be a common EKG finding. Beautiful. Folks are putting in sinus tachycardia, which is the most common. You have S1Q3, T3. Again, evidence of right heart strain. You can see T-wave inversions in pulmonary embolism. So again, just really pushing you all to think about what else would you find in the vignette? How else can this be treated? The last pro I'll have for you, and I dropped that hint in the last one, pulmonary contusion, obviously related to trauma, but you can have infarct of the lung as a result of a PE. Depending on where exactly that PE is, you might see more of a wedge-shaped infarct. The physiology is the same as the spleen, as the kidney. It's blocking off the blood supply to a particular organ, and that wedge-shaped of the territory that would have been supplied were it not for that occlusion.
And Moses, really quickly on the previous slide, I just want to point out that we're working now with contrast here. And so, I think a lot of us know that when we do, PE studies, it's always with, CT angio, CT with contrast. And the way that you recognize that we have contrast is that if you look at our vessels here, we have our pulmonary arteries, we have the, the aorta, they're very, very bright. And so that means that there has to be some sort of bright intensity that's causing that to happen. And that's the contrast that you're getting. But then on the other hand, you can clearly make out the clot, which is not enhancing, because that's not going to be, that clot is not going to, capture that contrast because it's not blood. It's an area of an actual clot. So that's how you're getting that contrast. How do you get that contrast is because you gave, contrast gives contrast. So just something to keep in mind when, when you see that those vessels become like very hyper intense, you're probably in a contrast sort of setting.
Thank you so much for pointing that out. Super, super high yield.
So, this image, it's something that we've kind of gone over a little bit. It's a little bit of a different flavor, but what I want to just, I don't want to beleaguer this one too much is that, what if I gave you a history of a patient who has history of dialysis, has missed their last couple of dialysis sessions, and you have, you have kind of some sort of pathology going on. If I give you enough history, you should be able to figure out, you have this patient with dialysis, what happens when people continuously miss dialysis? They get fluid overload. Where can that fluid go? The fluid will go, in all parts of the body. They'll get some lower extremity swelling, but even in the lungs too, they'll probably get a little bit of fluid, and that's what we're getting with pulmonary edema here. And I think Moses is going to take this one over for us and kind of just point out what we're looking at.
So in a similar spirit here, when you have volume overload, here we're looking at a CT chest, a cut through. We see normal sort of aerated lung on top, and you also see some layering, some substance here that is appears almost similar to the same color as the muscle, but we know that can't be the case because we're inside of the lung and it's layering by gravity, which makes us think of fluid. And folks are already putting here a pleural effusion. If we were on a lung window, I suspect we'd see some amount of pleural, some edema as well in the rest of the lung. And here what's also being shown is that whenever you see fluid, I think of three things. I think water, I think pus, and I think blood, right? So you can have fluid in the lungs that is volume, heart failure, like the last one, you missed dialysis, right? It could be pus. Now, this particular picture, not so consistent with pus. You would think more of that as a lobar consolidation, for instance, or perhaps an abscess that is developing within the lung. And lastly, a hemothorax. Now, this is scary. It could be iatrogenic. Something got nicked during a procedure or something. But you could see some sort of hemothorax if a patient underwent trauma, was stabbed, for instance, all reasons to potentially develop some of this dependent fluid, which again, whenever I think of fluid in the body, it's blood, frank just fluid, like transudative, or pus.
And I think we had just a quick question of about atelectasis. When it comes to atelectasis, generally, yeah, it will not be nearly as homogeneous and organized. And that's what I would say is like kind of the biggest, the biggest distinction. Atelectasis will like kind of just look like very subtle findings. And the bigger thing is that, if you have like a post-surgical patient, they're not doing the incentive spirometry. They may have a little bit of atelectasis. Sometimes it can cause a little bit of like, a fever, or it can also like kind of give you some indication of some lung changes, but nothing as frank as this sort of pathology that we're seeing here.
Awesome. What's your approach to head CTs, Roshan?
Yeah, so we're going to go over some head CT approaches in the next couple slides, and I'm going to try to go over exactly how I would address each of these topics. So the big thing with head CTs is, one, we get them all the time, so it's honestly important in most fields to be able to recognize them. So what I would say is the most important thing is to recognize is blood. Blood should not be in the brain, and whenever it is, there's a concern. We're going to briefly go over the cisterns. We're going to, also talk about the brain and the ventricles. And I think the best way to just get into it is with some examples. But the big thing to know is the more normal chest head CTs you see, the more comfortable you'll get that something is abnormal. So first I want to start off with blood. Blood actually is very interesting when it comes to imaging, is that it has its phases. So acutely when blood, when you have blood in the brain, it'll appear hyper intense. It's a hyper dense sort of demarcated then, and that's something you'd see like when the acute subdural, you'll very clearly see like kind of this bright intensity. And that's why, we're going to show you some examples of subdurals. You can have like kind of different phases where the blood looks like, you can tell that someone's had multiple falls because you'll see some areas of bright blood, but then you'll see some areas of more subacute where the blood is actually isodense. It looks like the same color as the brain. And the reason for that is because the macrophages are kind of digesting that hemocysteine. You're no longer getting that hyperintensity, and it looks like about the same size, the same color. And, there's a term that we like to use, Hounsfield's units, which is basically just measuring different densities in imaging. So it'll look like, appear similar to brain tissue. Then what happens is eventually that blood will get resorbed, right? So now when you have a chronic kind of subdural issue, you're going to get an answer, an area of hypodensity, because that's where tissue was previously and no longer is. And it was kind of just filled up with like, support cells, glial cells. So this is something I would say is particularly high. You'll just getting an idea of what blood looks like. If something is bright, that's probably means you're dealing with some acute sort of pathology. Whereas if it's much more chronic, it's going to be much less prominent in the backdrop of the brain. And then this is something that I think is, I would say is the most important thing when it comes to looking at head CT imaging. Is just like, the different locations. So you have the subdurals. That's something, remember I was referencing the different colors. It's more banana shaped. The reason for that is based on like kind of how, the anatomy works of where your subdural space is. But, if you see kind of this banana shape where you see like different sort of intensities, you see that area of hyperdensity and then isodensity, then you know that you're probably dealing with a subdural sort of pathology. Epidural, much more like kind of like dome or lemon shape. It's much more, demarcated. A lot of people have different ways of describing it. Crescent is another way to describe it, but it's very, it's not very irregular. It's very a smooth contour. The history is really important with the epidural. It's when you have sustained head trauma. You're going to have, they may mention the middle meningeal artery is the artery that gets ruptured. The patient will initially seem lucid. They'll seem like they're perfectly okay and then rapidly decompensate. So epidural is an example of one that they can ask so many different, this question so many different ways. But if you need to, one, recognize the buzzwords and like, for instance, the lucid interval, the middle meningeal artery, but also recognize what it looks like. So any different flavor that they ask, you'll be able to recognize. The next is where we're talking about interventricular hemorrhage. You can happen that the most common association I want you to be thinking of when it comes to that is that if you have a ruptured aneurysm, the aneurysm, the blood is going to be filling into these potential spaces. Those would be the ventricles. So whenever you see that, where like almost like you see that the ventricles, which you can kind of see them in the subdural picture, where you can see that there's those areas of darkness. Those are the ventricles. When they're filled with all that hyperintensity, that means you're dealing with an interventricular hemorrhage. You should really want to be thinking about a ruptured aneurysm. The next sort of hemorrhage that we're dealing with is parenchymal. So this example would be that you get a patient who is coming in with stroke-like symptoms. They come in and then you get a head CT. Now that you see this, now the next level of what they might ask is, okay, is this patient amenable to getting TPA? And this is an example of where you do not want to give TPA, because now you see that there's blood in the brain. That's an interparenchymal hemorrhage. It's an absolute contraindication to giving TPA. So a lot of what I'm doing is like, whenever I see these images, and most often when I, see, common things are common, how are they going to ask me that? And then finally, the subarachnoid hemorrhage also can be associated with the ruptured aneurysm. Maybe they would give you this image and then say, what is or maybe they'll present, they'll give you a history of a patient with the worst headache of their life. maybe show you these 5 images and say, what are you most concerned about with this patient with the thunderclap headache? And then, maybe they're asking you to select that subarachnoid hemorrhage and being able to recognize that.
Beautiful. What a tour de force of blood in the brain. I couldn't have done a better job. I'm going to briefly go over some other aspects of head imaging that frankly will not be the primary focus of the questions that you'll encounter in your examinations. Here, you'll just see some graphics of cisterns, various spaces within that you can identify on the CT head. Honestly, Roshan already talked through some of the major implications, reasons these are important related to blood, but I'll also point out that the various cisterns and spaces in the head can give you clues by their expansion or their diminution to other pathology. So for instance, if you see that there is an effacement of the cisterns, you would be thinking about increased intracranial pressure. Maybe they would give you a patient with some papilledema. I'm not going to say more out of fear that the ophthalmologist here would upstage me. But all of these different disorders that can lead to increased ICP could potentially manifest as radiographic findings. I'll also point out that, again, just really hammering home, the body loves symmetry and it loves homogeneity. This is the example relevant to the head. When you see areas of different density in the brain, something has gone wrong. When you see a lack of symmetry with midline shifts, something has also gone wrong. And sometimes it's something relatively easy to fix, surgically or otherwise. And sometimes it can be the clue to a really devastating diagnosis like a brain cancer that might cause significant problems for the patient. But of course, you want to be really attuned to this because changes in intracranial pressure, midline shifts, these can be early signs of herniations and other devastating clinical scenarios for your patients. And so just keeping an eye on that and correlating it back to your vignette will be really important. Similarly, I showed an image of the cisterns and the ventricles where you basically couldn't see them. Here, we have an example of when the ventricles are larger than what we would expect. And again, we're running out of time a little bit, so I won't dwell on this, but you might imagine that if there's obstruction to the flow of CSF throughout the brain, you might see enlargement of the ventricles, and often the precise pattern of which ventricles are enlarged can give you some clues as to the anatomy of where the obstruction might be. That's some pretty advanced neurology and neuroanatomy. We'll leave it here. I just want you to have seen what basically small cisterns and ventricles look like, normal cisterns and ventricles look like, and then what hydrocephalus ends up looking like. Here is just an example of bone. So this is cut, and you can see the various sinuses, right? And here, what I'm pointing out on the left side of the body here is what looks like a fracture, an orbital fracture, as someone already put in the chat. So you can see a lot on the CT face. You can see signs of inflammation. You can look at bony abnormalities. Often these studies are obtained when there's a suspicion of like a fungal and a sinusitis that might be fungal in nature, which can be really devastating, something like mucor or rhizopus. But again, the clinical vignette here, if this was a vignette of someone with trauma, you are already looking at the bones and you would note the orbital fracture there, the infraorbital. Awesome. Roshan, take us away with some other pathology that you might see with central nervous system imaging.
Yeah, so, MRIs are probably, definitely the hardest to get used to get comfortable with. And also, the examples of something where, it's important to be able to recognize maybe that you're seeing an MRI, but there's not that much they're going to show you. But we want to just go over 2 particularly high yield images and, just kind of go from there. So on the left, remember just, Moses's kind of words about symmetry, homogeneity. You can clearly see that there's areas of hyperintensity, in this kind of image of the brain. And so what they're actually showing you is they're very close to the corpus callosum. These are, an example of something called like Dawson's fingers, which are very consistent with MS, MS where you'll get different lesions in time and space. But basically those areas of hyperintensity indicate that there is some sort of pathology. the big thing is just noticing that there is some sort of pathology. If you're able to recognize it's the corpus callosum, then you can really kind of work your way through the MS diagnosis. But just knowing that like there's no clear distribution for these lesions, they don't appear very symmetrical, and that's very pathognomonic for MS. And then finally, you're getting a lumbar MRI. I'm looking through, everything looks smooth, but then as I go to the bottom, more of like, and when I'm at the S vertebra, I see that there's like this kind of a protrusion, and that basically what they're showing you is that the disc is kind of outpouching in between the vertebra, causing impingement on the cord, likely causes some sciatica pain, and if it's really severe, it can cause paralysis. So, not too much I want to kind of go over with this. It's mainly just knowing that, the MRI, you'll get very clear demarcation of tissues. It's especially good for muscle, very good for highlighting the CSF. And what you can then use that is to just see, okay, what doesn't look like normal? What looks like there's just this very stark contrast from my normal sort of findings.
Awesome. I want everyone in the audience to take a deep breath, because that was a whirlwind tour. Really, so many different types of imaging modalities, different parts of the body. There's no way that we could cover all the pathology, but what we hope that you took away was, one, the need to be systematic, two, really some of the general principles of correlating the imaging to your vignette. And hopefully by seeing, 70 odd examples of imaging, you'll start to more instinctively distinguish between normal and abnormal. I'll just end by, again, plugging what we do here if you found this useful. But if you think, hey, maybe I would like some instruction like this that's a little bit more personalized, a little bit more on your schedule, please reach out to us. We do everything from going over high yield topics to creating custom schedules, to being both cheerleaders and maybe some drill sergeants for those who need that sort of accountability, as well as just mentorship and guidance in whatever exam or other next step you might be facing in your medical training journey. I'd really like to thank Roshan for being such an awesome partner with me, ask if he has any final tips or advice for the audience, and maybe have time for a question or two. We really also want to respect your time, knowing that you all are very busy medical professionals.
Yeah, so, I just wanted to wish you guys all like kind of the best of luck. I know it's stressful and you want to get the best score possible, but I think it's really important to just, trust your studying, trust your habits. And kind of what Moses said is that, everyone has different ways that they learn, and some people probably wouldn't benefit from a tutor. But if you think that, you could benefit from like kind of a structured sort of guidance, and what I think that, everyone benefits differently from coming to MST. I think some people just need the ability to really help, develop a very well-structured schedule that really, takes into account all, because we know what you guys are going through in terms of your clinical duties, your clinical obligations, how much time you have, and help you develop a schedule. And I think the one thing I really particularly like about MST is that they do a very good job of matching the right tutor with the right student. And so if me and Moses are definitely different personalities. We have different ways that we'd like to teach. We have different ways that we approach even, these topics. And if you found that, maybe you worked well, you would have worked well with one of us versus the other, then, I think MST does a really good job of matching you with that. Much like Moses said, I think, it was, I'm glad that we were able to share this with you. Couldn't have asked for a better co-host. And hopefully, we can help you guys, along the way.
Awesome.
Anybody? And let's see if there's any questions in particular. So far there aren't any questions coming up. But if anyone, wants to drop any like kind of last bits, we're here for the next couple of minutes. But if you guys are, hoping to head out, that's perfectly fine with us as well.
Amazing. This chat is full of future colleagues. Really appreciate all the kind messages in the chat. We'll give it maybe another 30 seconds if there's any last questions, and then we'll close things out. So don't be shy if you have a question. Of course, if it's something, we have one question. The difference between diffuse infiltrate pneumonia versus lobar on a chest X-ray. So again, I think that this is the sort of question that I'll answer on two levels. One, the step one or COMLEX level, and then in the real life level. So again, think about the underlying anatomy. You know, you have the right and left lung, which are divided up into lobes, and then you have the anatomy that goes from the macro scale all the way down to the alveolus. When you have an infiltrate in the lung, you end up with an opacification. And typically, what we refer to as a lobar pneumonia is a pneumonia or an infiltrate, typically infectious, although there are non-infectious causes of pneumonia, that take up an entire lobe of the lung. And the way you would pick this up on the exam is basically someone coming in with fevers, chills, they have a cough, perhaps sputum production, and a chest x-ray where one distinct lobe of the lung is opacified. Now, you know, a diffuse infiltrate versus a lobar, if it's diffuse and truly bilateral, then you would see it on both sides in both lungs, as opposed to just in one lung, it being lobar. I think that pretty much answers the question. Any other questions related to radiology in the chat? I'm not seeing. All right, I'm not seeing anything. Roshan, have a wonderful night. Everyone, have a wonderful night or evening or morning, wherever you are in the world. We wish you all the best with your upcoming exams. Please reach out to us if you have any questions. It's been such a pleasure spending some time with you going over radiology. Take care, everyone.
Best of luck, everybody.